All right. We're going to go ahead and get started, in part so that we all have time to have discussion at the end of the hour. So welcome, everyone. I'm Sarah Brewer. I direct our education program as part of our team core at Accords. I want to welcome you all today to a special guest lecture as part of our seminar program. For those of you who are maybe new to Accords or less familiar with us, a little bit about who we are, what we do. We are supported by the University of Colorado School of Medicine and Children's Hospital Colorado. We are a little bit of a unique one-stop shop for pragmatic research. So you can see some of the wonderful things we provide to researchers across campus, and I'll specifically highlight two of our cores today. So we have worked closely with the Learning Health System core and the D&I program to put on today's special guest lecture. Some upcoming events, so we'll get this out of the way before we dive in today. We've got a few more seminars before the holidays this year. So next week we have part of our emerging topics in digital health and clinical informatics. We have Clint Carlson. On December 4th, we're launching our seminar series on transforming and advancing a learning health system, multiple perspectives for mutual gain with Eddie Stenaheim. And December 9th, we have the fourth in our digital health and clinical informatics series with Annie Collier. And then just a plug, in the spring, in February, we are piloting a new workshop on pragmatic research planning, and registration is just about to open, so that's something you're interested in, keep an eye on our website. And then lastly, save the date for the Colorado Pragmatic Research and Health Conference. This will be June 4th and 5th, right, for those of you who are here in the room, right down the hall. All right. Before I introduce our speaker, just a couple of housekeeping things. If you're here in the room and haven't yet, there's lunch outside. Please go ahead and sign in for us. If you are on Zoom, please go ahead and use the chat throughout the talk. We will have some time for Q&A at the end of the hour, and we'll be watching that. And then lastly, no matter how you're attending, please take a minute to complete our evaluation. We love to hear your feedback about all of our programs. Okay. For today's seminar, I am really excited to welcome our special guest, Alanna Kulchak Rahm, from the National Human Genome Research Institute. Dr. Kulchak Rahm is a certified genetic counselor and implementation scientist with a PhD in health and behavior science, both from the University of Colorado. She's spent her career specializing in the integration of implementation science and patient engagement in the implementation of genomics and precision health in healthcare systems. She's currently in the Division of Genomic Medicine at the National Human Genome Research Institute and program director for the Network of Genomic Learning Health Systems. She's previously a professor in the Department of Genomic Health at Geisinger. For over 20 years, she's conducted research on new paradigms for identifying individuals with genomic risk and new service delivery models for genomics, ethical and legal implications of genomic information, communicating genetic test results, familial implications of genetic test results, patient and provider understanding of genomics, and patient engagement research. So please join me in welcoming Dr. Kulchak Rahm today for her presentation, Implementation Science and Precision Health. Welcome.
Thank you so much, Sarah. Thank you, everyone. Thank you. And thank you so much for having me here. It's really nice to be back in my old stomping grounds around so many familiar and friendly faces. So thank you. And basically what all that means, that Sarah said, is I know an awful lot about everything to be really dangerous, but I know just enough to be dangerous. Anyway, thank you so much for having me here today. I'm here to talk to you about my favorite subject, about implementation science in genomic medicine and how it really can be the key to hopefully maximizing what we've talked about for many, many years, is the promise of genomic medicine and being able to use genomic information in health and healthcare and prevention. So hopefully what I'm going to talk to you about today is, again, just a little bit overview of implementation science from that lens, or in the context of precision health, genomic medicine, and prevention. Also should identify some of those gaps, what's going on in research, and the gaps that are still remaining in all the work that we really have left to do in this space. And to talk to you a little bit about some of our ongoing and open funding opportunities that we have at the NHGRI. So first of all, I love to talk about this. Why is this? How does implementation science help us, and why do we really need to think about it in genomics and genomic medicine and precision health? And I think all of you know, it's a lot like building the plane as we're flying it over the past many years that we've been doing this. Our evidence continues to grow rapidly. It shows no sign of slowing. Our guidelines are changing, they're expanding, new laws are being made, our testing is changing and expanding, the costs are decreasing, or as new treatments come out, costs are astronomical depending on what you're looking at. And oh, by the way, our organizations are continually changing, merging, de-merging, growing, all of that. So we don't have the luxury of waiting until all of our evidence is in before we can implement. We really have to figure out, how do we evaluate what's going on, the effectiveness, the utility of these genomic medicine programs, some of these things that just end up, policies that end up getting made. How do we evaluate that while we're doing it and facilitate the implementation of these programs when evidence and environments are changing constantly, and we don't have that luxury of doing all of the perfect research we'd love to do. And that's where implementation science comes in. It offers us the tools, the methods for putting research, translating evidence into routine medical practice, helps us translate guidelines from development into deployment, helps us evaluate solutions and extract evidence when things happen in the real world, and do things in the real world environment, do our work in that real world environment, to really understand what's going on. It's integral to the operationalization and ongoing functioning of our health systems. And it really helps us with integrating tools, designs, methods together so that we can identify what works for who, why it works or doesn't work, under what conditions, when it works, and how does it work differently in different situations, or basically what works for who, when, and under what conditions. And I love to use this cartoon because I really just think implementation science is step two. That's, we're really looking into that black box of what happened. Why did it work? Why did it not work? How do we make it work? Instead of just going, it might not. So that's implementation science. It helps us be more explicit in step two. So this is one of our models. We have a lot of theories, models, and frameworks, which I'll talk about in a second, in implementation science. This is one, the conceptual model for implementation research, but I put it up here to show how implementation science helps us think differently when we're implementing, and implementing in genomic medicine particularly, but in any implementation science work. And it helps move us from the typical way we think about research, which is usually going from what we're implementing, that intervention, that evidence-based practice, if we're lucky, the quality improvement program, whatever it is that we're implementing. And then we usually just go straight to what were the health outcomes that we were measuring and use that to say, did it work or did it not work? And we kind of skip over all of this stuff in the middle, the how it was implemented, what did we do to implement it, what were those, did it reach who we were intending to reach, what were the costs of it, was it feasible, was it patient-centered, did it happen at the right time, all of those type of things that may have impacted the health outcome. How are we going to know if it really worked or didn't work if we don't know the impact of how we implemented it? And so that's where implementation research comes in. It really makes us look at those things. How did we implement it? Those implementation outcomes and those service outcomes. And implementation research really changes our thinking to thinking through all of that while we're doing the research, rather than just going from what did we do and what was the outcome. So it gets us beyond that typical research thinking. And another way to put that, we have from Jeff Curran from a couple of years ago now, is this sort of implementation science thinking in a nutshell. But I really like this because it really helps us communicate this difference in thinking and what is an implementation outcome, what is an implementation strategy, all of that stuff, and what is the typical research. So if we think about what we're implementing as the thing, that can be the program, the intervention, the practice change, whatever it is, that's the thing. Typical research is when we're asking, does the thing work? And we always need to ask, does the thing work? Did it work in the way that we did it? But the implementation strategies then are the things that we do to help the people and places do the thing. And then our implementation outcomes, those service outcomes, are how much and how well those people and places did the thing, right? So that's a really nice way of thinking about it, but that's also kind of, it's also thinking about it, it's very prospective, right? So you have something, you're implementing it. How do you know how you did it? What did you do to make it work? And what were those outcomes? And so while it is simplistic and it's a wonderful way to start our thinking, we also have to remember in implementation science, and especially in genomic medicine and precision health, we may not always be ready to quite implement it, or something may have been implemented in practice and we need to understand how it's being adapted, things like that. So we really need to think through all of the different stages that we might be doing something that, or the continuum of implementation work. You could be in a pre-implementation space. You need to know, is it going to fit? Is it feasible? Is it even the answer to the question or the problem that your constituents are thinking of and need an answer to, or are not doing that they're supposed to be doing? Are you at primary implementation, ready to implement something? That what we were just talking about, what is the thing? Is it needing to be adapted to different populations, to different clinical environments? Are you trying to scale it up? Are you trying to make sure it's sustained in a health system, institutionalized so that it's constantly going and still having those outcomes? Or have new tests come out and you need to see, do we need to change it? So are you in that evolution and change space? And so while this is also linear, it really is kind of a circle. I just like it linear because I think that helps in the thinking through of where are you on the continuum? Because really, if you're at evolution and change and you're trying to say, do I need to change to a new way of doing things, you're kind of going back to pre-implementation. And I apologize to you online. We're using the camera that is on the laptop, and I tend to move. So if I'm stepping away, it's because I'm moving while I'm talking, and I apologize. So I may come out of the frame of the camera. But when you're doing this, so thinking through those stages, you just have different research questions that you're asking, and that's kind of how you can locate yourself of where you are in these in this continuum of implementation. If you're pre-implementation, is it feasible? Do you even have the, is it what your stakeholders want? What are the barriers and facilitators? What strategies might work, might not work? Whereas in primary implementation, you're asking those different questions of what did you do? What did you do to make it work? What were those outcomes? And then adaptation and sustainability, as we talked about. What are the costs of sustaining it? Can you even do it? Is it paid for? Is it not? Is it institutionalized in that ongoing quality assurance in the evolution and change? And is it time to change it and de-implement what you're doing and implement something new? And so that's kind of where, that gets at that thinking of where you are on the continuum. The other issue we face is that it's also multi-level, right? So implementing genomic information, using genomic information in care, it's not just about getting a result to a patient and giving that information to a patient, right? It involves has implications for the family. The clinicians have to care for that individual correctly. So it's this, if you're used to the socioecologic model, that's pretty much what this is, right? It's this whole multi-level idea of everything that impacts that. The clinicians, the departments that they're in, the health systems that practice this work, that do the genomic medicine, the payers, and our national policies, and even the media. We all know what happened when Angelina Jolie went public with her BRCA mutation, right? So that had a huge impact on genetic testing and genomic medicine. And so, so one of our challenges is it's also this multi-level thinking. And so, this is where implementation science helps dealing with these challenges and opportunities. So, because we know that in the real world, healthcare and outcomes of that healthcare are already inequitable, and we're trying to use genomic medicine to identify people, and we want to not exacerbate those inequities, but reduce them and make that equitable. We can conduct the research in our health systems where we can address those issues, those multi-level issues. As Larry Green said years ago, if we want more evidence-based practice, we need more practice-based evidence, right? So we need to be getting that evidence that's coming from practice, as well as the research, getting research into practice. So conducting research within our health systems in that context where this is happening can help us identify process issues, patient level issues, help us with that multi-level thinking and understand what's going on and how to use those levels and multi-level issues and work with them. And it also helps us with that ongoing evaluation, learning cycles, making sure we're having the impact we're supposed to have or we should be having, and who they work for, who these interventions work for, who they don't work for, and what else we need to do to make sure we're doing what, getting the benefit for everyone of the genomic medicine. And so that's, this wonderful, brings us to this sort of this diagram, this level of synergy published by David Chambers and others a number of years ago. So implementation science is the tools that we're using to help us implement precision medicine. The learning health system is also the place that helps us do that. So it provides that environment that can help us generate that practice-based evidence. And this is just sort of my idea of my diagram of what that kind of looks like in actuality. So it doesn't matter where the evidence is coming in from. Sometimes it's coming, you may have had something that got implemented, testing that's working, a program that you've had in, you're doing the QI on it. That's your practice generated evidence, and that's going in and helping you generate more hypotheses, optimizing real world outcomes, and even trialing for feasibility if you're in the early stages, understanding the feasibility of it in different settings, different clinical settings maybe. Or you might be coming in through with evidence-based practices, other things through the research generated evidence and going into practice where you're testing implementation strategies, testing different interventions, implementing guidelines or new clinical guidelines that you might be tasked with implementing. So that's kind of what this looks like. And of course, always with that multi-level thinking, the patients, the family, the clinicians, our systems, and that at the center of all of this. And that also, as I've talked a little bit about this, and this is a new kind of thing, thinking through this, there's new policies always coming out too, new clinical policies as well as laws and that also impact. And we've often put it, and as you've seen, I've put it in that outer level of those circles. And even in our other theories, models, and frameworks like the Consolidated Framework for Implementation Research or CFIR and others, we tend to put policy in the outer setting and think of it just as something that's impacting. But we're, one of the areas that is really ripe for work and we need to be thinking more about is what is the impact of policy implementation and how it's implemented differently in different environments on genomic medicine and its health benefit for people when it's implemented. So, that sort of changes us from thinking about policy in this outer setting. We know it has an impact, but we don't know what it is, to really thinking purposively about it, and maybe thinking about it as the thing. And then that shifts us, if we think about the policy or the guideline as the thing, then we start thinking about the how much and how well people and places do it as having that impact on, does it work or is it not working, and all the equity issues with that, and what did people in places do to implement it, and what were the outcomes of that different variability in implementation. So this is just sort of my thinking forward in that space. This is a place that we've always talked about in implementation science. We really need more work, and I think again, with all of our different clinical guidelines, this is a huge open area for genomic medicine. But really, so as I've talked a lot about this, I do want to bring us back to how implementation science helps us in all of this. And I like to think about implementation science as our toolbox. As I said when I showed those, how those three things work together. The learning health system is where we do it. Genomic medicine, precision health is what we're doing. Implementation science are the tools in our toolbox to do that and to generate the evidence in the health systems, in whatever environment, communities, different health systems that we're working in. And those tools in our toolbox are the, there are theories, models, and frameworks. We have over 100. We beg, borrow, and steal them from multiple other disciplines because implementation science is so multidisciplinary. We were just talking earlier, it's very adaptive. If it works from another discipline, we can use it. We use many different study designs, from hybrid designs to observational, retrospective, prospective, randomized, non-randomized. We can use any study design and adapt that study design to the question that needs to be asked. We use multiple methods. Basically, we use all the methods: qualitative, quantitative, mixed, multi, coincidence analysis, all sorts of different methods we can integrate and use to answer those questions. We have tools such as intervention and implementation mapping that help us work with stakeholders to create those interventions, to figure out what implementation strategies will best fit in this, the context with those stakeholders. We have tools like the Frame and the Frame IS and other tools to track adaptations that are made in real time or prospectively or retrospectively, and reporting on the impact of those adaptations or modifications. We also have tools that help us with engagement methods as well, because again, I've talked a lot about engaging stakeholders here and is it feasible for stakeholders, things like that, because really engagement is a core component of implementation science. And it helps us, and really just when we're thinking about this, co-creation with those who will benefit most is really where we should all be doing our research, right? We should really be thinking about that no matter what type of research we're doing. But it is a core component of implementation science. It's kind of can't be, to my mind, it doesn't, you can't separate it out. It's a core part of that. It helps us regardless of where you are in that spectrum of implementation, whether you're in pre-implementation, primary, adaptation, change. You have to do that with your constituents, your stakeholders, those who are needing to benefit the most out of it. It helps us mitigate in this space specifically. The engagement can help us mitigate, hopefully, those biases from big data. We know our algorithms in genomic medicine are created in certain populations. So how do we engage more populations to get the data that we need, but also answer the questions that are important to those folks, right? So hopefully that's a way with this engagement that we can help mitigate that and not exacerbate issues that are already inherent in genomic medicine. And we have in implementation science, there's lots of work that's been done in this space. This is some work by Caitlin Allen and Rachel Shelton. They've really brought out how some of our implementation theories, models, and frameworks really help to incorporate equity in precision medicine and public health specifically, and how we can use that equity lens in this space. It helps us with that engagement. helps us think through our models and frameworks. They can help us choose the theory, model, and framework that we need to be using. They help us develop, select, adapt our interventions, our evidence-based practices, what outcomes we need to measure, the evaluation approaches we need to use, how we need to use them, as well as the implementation strategies that we're going to use. And the best way to do is most of the theories, models, and frameworks do have some sort of an equity lens in them, but this is just to make you think, help you think proposively about that equity lens within those frameworks that you might be using, or to use one that specifically has an equity lens. But I also often get asked, well, what's the right theory, model, framework? What's the right design I should use, that I should always use for implementation science? And it's use the theory, the design, and the methods that fit what you're doing. What's going on? What's important to your stakeholders? How much control do you have? And what's the important question, right? Are you trying to look at something retrospectively where you have tons of variability? Are you trying to do something prospectively? Has something been implemented, just gone gangbusters in a system, and you need to understand what it's doing? You may not always have the luxury of your prospective randomized controlled trial, but you can always collect data from whatever is happening. And every way you ask the question every study design has strengths and limitations. You just have to know what your questions you're answering, how you're answering them, and match what you're doing with the information that you're getting. And so basically, they're all wrong, but they're all useful. So just remember what you're doing and use what fits your purpose. And sometimes it's okay to change it too. And sometimes you may need to use multiple ones. So really, this brings me to, hopefully in this whole section, you've seen that really, I like to think of this as this genomic medicine and the implementation of genomic medicine and precision health is that paradigm shift from how we typically do research. Really incorporating implementation science into that helps us go beyond the building it. It's not just about giving genetic information to a patient. It's thinking about the whole process. How do we help the patient, the systems, everything use that information? Because the point of giving that information is to prevent disease, to treat things, to help with better health outcomes, to use that information, right? So it's beyond just building it. There is no one best practice. What works in a high functioning learning health system you can still do it reach those outcomes in an FQHC or a lower, differently resourced setting, but you may have to do it differently, and that's okay. And also thinking about implementation as the next mile. Think about those implementation outcomes, what was being implemented, how we're helping people and places do the thing, what are the outcomes of that, how much and how well are they doing it? Those are next mile questions, not last mile, because we don't have the luxury of waiting till we have all the data. And so where years ago we used to think about implementation as the last mile, after you have all the evidence, then you can think about implementation. This is really thinking about how we implement and its impact on the outcomes that we're getting. And again, learning health systems, any health system, doing this in context, generating that practice-based evidence is one of the ways we can do that. And measuring those implementation outcomes as we do that is one of the ways that we can hopefully learn better and faster and really help people benefit from genomic medicine and genomic information. And that is, so to bring me to some of what are our open opportunities. How are we doing this? How are we doing this in the Division of Genomic Medicine? And that is kind of specifically what we're doing there. And one of the reasons why I've gone to the Division of Genomic Medicine is our actual goal is to promote the institutions, the NHGRI's efforts to advance the application of genomics to medical science and clinical care. And we do that by planning, directing, facilitating multidisciplinary research to identify the contributions of human health and to advance approaches for the use of genomic data to improve diagnosis, treatment, and prevention, right? Everything we want to do, incorporating implementation science into genomic medicine to make this work. And while we have a lot of different ways we go about this, the one I really wanted to focus on is two of these things that we need to think about in order to develop processes for clinical genetic testing and using those results in care. Again, with that multi-level thinking, we need to not only facilitate healthcare systems and how to adopt genomic medicine in multiple levels, right? So the clinicians to care for the patients, as well as giving patients the information. We need to also build capacity within our clinicians and our researchers who are embedded in those systems to use this information. So we need to build capacity through education of current and new generations of clinicians and researchers in genomic medicine. And so one of the things that we're doing is, as of last month, at NHGRI, we have funded the network of genomics-enabled learning health systems, which this is one of our really exciting things. So we have funded 6 clinical sites, and a coordinating center that this is the goal, is to really see how we can implement genomic medicine, moving that genomic knowledge to the clinic. And this is not like a new, this has been many years in the planning. So this started from a National Academy's report on the genomics enabled learning health system and what it might look like in 2015. And then the genomics medicine 14, there's a genomic medicine conference every year. And back in 2022, they talked about how would we actually do a genomic learning health system. And so that all of that has led up to us, as of last month, funding these sites that are hopefully going to do this. And that is, the goal of that was really to take those 3 pieces, the genomics, precision medicine, the learning health system, and implementation science together to create the genomics-enabled learning health system, where we can have those ongoing learning cycles. We've got the environment, research and practice can coexist. And we can learn from what we're doing. And we're using implementation science while doing it. So we're using the methods, using all the tools in our toolbox, using our frameworks, generating real world data, and trying to understand how we can use that to create programs and create implementation practices, I don't want to call it best practices, but practices and the ways to implement that can be used in any setting. And so that's the objectives of the network. So they are actually, over the next 5 years, they will refine and develop existing learning health system and genomic practices into resources for use in health systems and in healthcare for implementing genomic medicine. And they're going to actually implement 2 to 4 projects across the network so that we can learn from that and hopefully establish tools and resources for use in any healthcare setting as we go along. And so that's one that's currently funded. It just started. And so stay tuned. We hope that this will bring up some really good evidence in the next 5 years. We also have our open funding opportunity for population genomic screening in primary care to understand how can we actually do this in primary care. How could this work? And we intend to create a network that will include about 4 or so clinical sites, a coordinating center, and a sequencing center. And that application is due coming up on December 2nd. And we had a webinar last month for it that is available on our website as well. Hopefully the FAQs, I think, are up there now too, because we had a lot of questions about it. We also can fund investigator-initiated research. So if you're just wanting to do even a small R03, R21, or R01, our AGMR, Advancing Genomic Medicine Research initiative, is once a year in February. Those are due, and they do get reviewed within by a study section that's within NHGRI. If you can't make the February, we also participate in the DIRH, the Dissemination Implementation Research in Health. And that also funds some of this research in this space in genomic medicine. It does get reviewed in a larger DIRH study section. But those have the regular 3 cycles per year. And I should say these are, both the AGMR and the DIRH are being reissued. So these numbers, while there are links in the slide set, these numbers may change. But if you go to these numbers, once they are reissued, it should take you to the correct NOFO number. We also have small business opportunities, SBIRs and STTRs, that are linked specifically to the population genomic screening, as well as the genomics-enabled learning health system and the AGMR. And these are for funding tools that could be that are created in the small business environment and maybe in partnership or not with health systems, but also for helping to implement genomic medicine. And then we also have our fellowships coming up. So we have the NIH ACMG Fellowship in Genomic Medicine Program Management. That's a full-time 2-year fellowship, paid experience, that is open for physicians, physician assistants, nurse practitioners, and genetic counselors. In fact, our 2 current fellows right now, Rachel and Nicole, they're on the end, are genetic counselors this year. And those applications are due December 6th. For that program. We also have a post-baccalaureate program for program analysts. That's an NHGRI ASHG fellowship program that's due January 5th. These are for folks who are within 3 years of their bachelor's degree, and they can come work with us for 2 years as program analysts, kind of like a research assistant. And I said those are due January 5th. We also, because again, we want to build capacity for people who can do this work in the health system, right? So we have all sorts of funding opportunities for training from graduate, pre-doctoral to postdoctoral, but I want to focus on we have a K01 for a mentored research scientist and a K08 for mentored research or mentored clinical scientist. And both of those are ways, if you're not familiar with K awards, that is a way that you can incorporate learning implementation science into your into what you're doing, into your growth as a researcher. So these are specific training grants to help you build your independence. I've had junior faculty do that before, where they've actually done certificate programs and that in implementation science within their K awards. So it's a wonderful way to do that. And then, okay. We also, I just want to bring up our loan repayment programs. We do participate in multiple of the loan repayment programs, but specifically our REACH program, which is for genetic counselors at the master's or doctoral level involved in genomic medicine research. So, and that is only at NHGRI or master's level genetic counselors eligible for the loan repayment program. So I think that's a wonderful thing that we're doing to make sure, because genetic counselors are our implementers in this space. And so we want to make sure that we are supporting them. And those applications are due November 21st. And of course, you can go on our website and find all of our funding opportunities. And as I've said, we also building capacity through training is another way to do this. And there are a lot of certificate programs in implementation science, including one here. And you can match them to whatever is your style of learning. Some last from 2 weeks to 2 years or more. I think there are even doctoral programs that are incorporating it now. But there's also online open access through the NCI Implementation Science Group. There's the Open Access Training Institute for Dissemination and Implementation Research. And then as of September, we just completed our first facilitated course for where we did the titer for genomics and precision public health. And that is also posted online, where we took the existing open access course from the NCI, and there are actual readings and sort of initial recordings of people working in this space. So introducing that genomics and precision public health lens to each of the modules, including one by Katie here. So each of the modules has an introduction and some reading that helps you frame it in genomic medicine. And so again, if you can't go to one of the training courses, I do highly recommend that you take a look at the open access course. And of course, so I think with that, I will just say thank you to all of our, we have a huge division of genomic medicine. We have a number of all of our programs implementing genomic medicine in clinical practice. We don't have the genomic learning health system up there yet because it's only a month old, but eventually it will have its own logo as well, and we'll get to live up there. But hopefully this has inspired you, given you some ideas of how to use implementation science, why it's so important in this space, and some of the ways that you can even fund this research. And thank you so very much. I'd love to open it up for questions and discussion. Thank you. And again, sorry, at this point, I probably will keep moving in and out.
Start with the questions. We have a few comments in the chat that I'll bring up, but if you want to have some questions to start with, go ahead.
Hi, Alanna.
Hi, Jan.
So I think that one of the conundrums with implementation of genomic medicine is that for most, insurance won't pay for it, right?
Mhm.
So if you're going to implement colon cancer screening, we will pay for that, but those studies, those are efficacy trials that weren't tested for implementation science. And yet we say, it's okay, we know it works, we'll pay for it. So with this implementation, what is the evidence we're going to need at some point around genomic medicine?
Right.
Is it going to come through this implementation science outcomes to ship it back to insurance companies and say, hey, if you do this in the healthcare system, because Katie, I've got to be part of the biobank here, and the only reason we were able to do testing is because it was a research project. Well, that's not going to work.
Right.
So how do you see the landscape, and how are we going to get that evidence? Where's it going to come from?
Yeah, yep, I will repeat that. You hit on the catch-22. So Jan's question was really about, I'm going to try to paraphrase it into what is the evidence, or how will we generate that evidence? What is it going to look like? Because right now our conundrum is it's not paid for by insurance. And I think you're specifically talking about the population screening. So I think a lot of that is going to come from both the evidence we can generate from getting the people who already are tested, and we do know their status, their risk status, whether they have the condition, things like that, actually getting them in care and showing that once we do the care that we're supposed to do from that genetic result, that we can improve outcomes enough that will help change the environment. But I think the population screening is probably going to be, it may still stay in select at-risk populations first, whether it's just everyone with a cancer diagnosis. That may start expanding over time. And we need to keep generating that practice-based evidence from those. But even our population screening program, that is the funding announcement that's out now, that's one of the reasons why we have the sequencing center, because we know it's not covered. We need to generate some of this evidence though, and that's our thinking with that. And we will, it's very heavily on the implementation outcomes as well as the what is the effectiveness, does it work to give this information back.
Yeah, so it seems like for those studies, individual patient outcomes,
Mm-hmm.
we have to do it.
Yeah, we still have to do some of that work, yes.
It's not a traditional implementation science outcome, but in this case, It seems like it would be really relevant to be able to go downstream as far as you can.
Yes, and so if you look at the RFA specifically for the population genomic screening, part of it is to connect, can we connect people to the care downstream? Which is, I think, what you're asking. Is that correct?
Or at least documenting what happened after.
Yes, what happened after, yes. And so, because that is currently a huge black box, even in, all of our biobanks. We've tried to look at that at Geisinger over the years as well. And there's a lot of evidence out there that of the people that have been doing this over the years, we get some people into care, but there's more work to be done there. And so we really need to figure that piece out. That is the big black hole that we have to figure out.
Katie, you had a question in the chat. Do you want to ask that loud?
Sure. So there's a handful of folks from Colorado Center for Personalized Medicine, Jan included,
Yep.
Online and in the room, and folks that do pharmacogenomics-based implementation work. And here at UC Health, CVS is the key for that, and there's a fair amount of it going on. And I'm just curious from your perspective, you talked a lot about equity and the bigger picture of things. When it comes to pharmacogenomic implementation stuff, what do you see as potentially the biggest equity issues around that we should be focusing on?
Oh, that's a great question. So what are the biggest equity issues we should be focusing on in pharmacogenomics? There are lots. I think there's equity issues everywhere that we need to be focusing on. But in the pharmacogenomics space, I mean, even with CDS, so you think about it in the clinical decision support, people have to be coming into the system, right? And they have to be using the system. And so if your clinical decision support is only happening at point of care when a diagnosis is made, you might be missing those people who are coming in at other times and may need that information down the road, or may already be on some of these medications and could use that information and understand how to change their care. There's also issues of the way people react to medicines. So a lot of the pharmacogenomics is around the side effects and things like that, and just using it as an education point for both patients and clinicians in generating understanding and use of genomic information. And so it can also be almost an in to improving the genomic literacy and understanding of how we use genomic information. And that could go a long way to improving the equity as well.
I'd like to add to that,
Mhm.
answer your question. At least relative to the biobank, which is research-based. I think you have to go way upstream to make sure everyone gets invited to participate in research. Do that by legal consent forms. I mean, back to the basics. Ensure you can access.
Yes.
And then if you're just using like your patient portal, you can everyone use the patient portal. So understanding that up front.
Yeah. So
dealing with it way up front, and then because when you get results, then you have more people to actually go to results too. But I think the upstream work is really critical.
Yep. So to rephrase what Jan was saying is she's talking about the upstream, making sure you have the reach. And that's the importance of thinking through, using implementation science thinking from the beginning. So even when you're in a research environment like our research biobanks that you have here, or like we had at Geisinger, and that exists a lot of other places. MUSC has one, a lot of places have them now. But are you reaching the people that you intended to reach? And that takes a lot of work. And we've seen MUSC published one of their papers recently. What worked for who? How did they get the most diversity when they were, they tried different methods to reach out and improve the reach. As Jan was just saying, when you're using just the patient portal, you're only reaching those people who are using the patient portal. So, even if it is in your consent form is in Spanish, only Spanish speakers who are using your patient portal and are comfortable consenting through that method are going to participate. So you're already creating inequities. You're already looking at the same people we always look at. And what are those methods that you can get better, more equitable reach? The MUSC study they reported on, the community events were the ones where they got the most diversity, the younger people, all of that. But that takes time and resources. So then we have to figure out, how do we do that?
A couple questions in the chat
Okay.
about the genomics networks that were just funded. So one, do the genomics network have a roadmap? For example, are they all working on a disease or genetic pattern to work from? Are they creating that roadmap? Is each center working on their own project, or are they intentionally working as a team of centers on certain projects?
They're
Tell us a little more about it.
Yes, so they are intentionally working as a team on those projects. So, and stay tuned, they are creating that roadmap together. That is what we are doing as the initial tasks of this network.
And then we have another question from Dr. Glasgow. Will the genomic-enabled learning network be able to include and integrate data on environmental, behavioral, cultural, and contextual factors, as well as that genomic information?
Yes, great question, Russ. That is the hope. Now, eMERGE is doing a lot of that too. So eMERGE is the eMERGE 4. Yes, it's eMERGE 4. Should be publishing some of their information about that coming up here in the next year. But in the GLHS, the Genomics Enabled Learning Health System Network, we do know we need to include that information, and that is part of our thinking from the get-go, how it's going to be included, how we'll be able to do that. Stay tuned. It may just come out without that information in our EHRs. We can't use it. So, or maybe what we will find initially is that, I mean, my sense would be it's unequally represented in the EHR, and how do we facilitate doing that? But again, hopefully at least bringing up where are the gaps and what are the impact of those gaps of not having that information on being able to provide care.
Julie's got a question.
Thank you. I really appreciate your emphasis on engagement and health equity. One of the grants I'm a part of, the team, we are researching a rare medical condition with a genomics component, and we really need people to participate, to submit their samples, their tumors and things, to conduct the nice genomic testing. And we have a conundrum, which is we're doing a lot of engagement as well, partnering with our stakeholders, the people with this medical condition, and they're saying, listen, I want my individual genomic results. And the geneticists are saying, well, we don't know exactly what it means. We don't really want to give it to you. And they say, well, I'm contributing. There's a bit of a reciprocity here, I expect. And I am struggling with trying to navigate this landscape because there aren't a lot of answers in my clinical condition. So I want all the information I can get. So do you have guidelines or thoughts on how to navigate? Because I think it gets in my mind, it really resonates for me about what you talked about. And I think that is where the rubber hits the road a little bit, where science, which I'm all an advocate of science, but will push back and will not really engage fully in a way that we, from the engagement side, would say you're not really engaging. But then science says, wow, but we have all these important reasons why we're not going to give you that. So, do you thoughts on
Yes. So I'm going to try to repeat the question a little bit, which was about that engagement, and particularly how do you facilitate that, or how would I answer a question about that related to the conundrum or the tension between the stakeholders, the patients with that condition wanting the information, and on the genetics side wanting to say, no, we don't know enough information to give it back to you yet. That's been an ongoing issue. And I think from my standpoint, the way I usually start answering that question is that's why the bi-directional learning is so important. And so it's not just training the researchers and the clinicians to engage the patients, but it's also training the clinicians and the researchers to do that engagement, to how they can work with communities, how they can return those results. How can they, I mean, I remember years ago when we first started talking about engagement, when PCORI was first created, there were so many that were saying, oh, but I can't do it the way that they want to do it. And well, that's part of the bidirectional learning. I worked on a study myself where we did this. And when I explained why we couldn't change the questionnaire that we were using, and why we had to use it the way we were using it, or why we were adding this one outcome, our patient representative was like, oh, now I understand that. Nobody explained that to me. I can go back and tell my folks in my patient advocacy group now why we're doing it this way. So it's that way, but it's also training the clinicians that just because, that there are still ways to do it. How can we say, instead of, no, we can't, but how can we say, well, here's what we can do? And use that learning process and create, frankly, ongoing engagement instead of one and done engagement. And some things I would encourage you to look at would be the Genome Connect and that model. I don't know if you're familiar with that. That's a model, I think it's through ClinGen, the ClinGen network, where, in fact, yes, it is through the ClinGen network, where patients provide their own information in. And some of the Geisinger models, particularly through ClinGen and the work out of the Autism and Developmental Medicine Institute, talk about how they can return results even when we're still not sure. There's been a lot of work out of that group on specifically genomics of intellectual disability and how they've been able to return some results, even though it's such a diverse conditions.
We have a question online from one of our implementation scientists here, who's also connected to the Women's Center for Women's Health. Does the National Human Genome Research Institute have priorities to evaluate with regard to sections of biological variable?
Oh, very good question. Do we have priorities for sex as a biological variable? It is a review criteria. So I don't think it's a score driving criteria, but it is reviewed. And it has to be appropriate to the study. So if you are doing a condition like ovarian cancer or something that is specific only to women, you need to explain why you don't have men. That's pretty obvious why you don't have men. Men don't have ovaries. Or if you're doing prostate cancer, women don't have prostates. But I'm not really sure how to answer that question in terms of if we're prioritizing men over women or women over men, if that's what you're asking. I think it's just, it's dependent on your study, and it does have to be justified and addressed within your application.
Any other questions in the room? Coming right up on time. Well, I will just say, I'll come up here and make sure that people can really hear me as we close it. So first, I want to thank you so much for taking the time to chat with us, both online and our folks here in the room. And then I'm going to put a little plug in for everybody in the room and online to please fill out our evaluation. If you're online, Jordan dropped it in the chat. And if you're here in the room, they're sitting out by lunch. So please take a minute. And thank you so much for your time today.
Thank you all for having me. Thank you.